Hi, this is Dr. Bernstein with our March 2020 teleseminar. Before we get on to the usual questions, we're going to hit a few special subjects. The first is a very disturbing experience that a patient of mine had in this past month. She was vomiting at home. We had it controlled with injectable Tygan, which she injected herself, which is routine for any of my patients who pick up a GI virus and are vomiting. And it usually works, and was working for her, but she ran out of Tygan. And the pharmacies don't stock the injectable Tygan. There was no way of getting an additional supply, so we had to send her to a hospital emergency room where they have the Tygan on hand, and they usually give it intravenously. And if by any chance they didn't have it and couldn't stop the vomiting, they could give her intravenous saline, which is what they requested. Well, she got there. They had the Tygan. They did not give her Tygan. They gave her a large dose of injectable Reglan. And she said, as she told me later, was the most horrible experience of her life. She felt that she had been hit by a lightning bolt and was shaking all over and hallucinating. And it's the reason I don't routinely use Reglan. Certainly not in large doses. It's in the USA, it's the standard treatment for gastroparesis, but I use other medications instead because of the adverse effects we see with Reglan. So the first problem was getting hit with Reglan. They gave her intravenous glucose mixed with insulin. This, by the way, was a famous children's hospital. She was an 18-year-old girl. A famous children's hospital, and they gave her intravenous glucose solution mixed with insulin, got her blood sugar over 300. Then, because she hadn't been eating for 3 days, she had ketones in her urine. They gave her more insulin and got her blood sugar down to 33. When they then gave her more intravenous glucose, got her blood sugar up high again, and when she's in the process of recovering from the very low blood sugar, she's in a daze. They give her a shot of basal insulin. In this case it was Lantus. She usually received about 1.5 units of Trulicity, long-acting insulin, twice daily. They gave her 10 times the amount. They gave her 35 units of Lantus. Did not tell her what they had injected. They just said, this is a medication that your doctor ordered. Her mother was in the room. They wouldn't tell the mother what the medication was. And for the next 24 hours, she was having severe hypoglycemia continually. At that point, although I was a few hundred miles away on the telephone, I had to challenge the hospital doctor and insist that he stop treating her and that I treat her over the phone. And we immediately went back to our routine, which was how much liquid glucose you drink for what depression of blood sugar. And we got her under control over the phone, and she checked out the next morning. It could have been a disaster. It could have been a fatality if I had not been in touch with her, um, giving her more than 10 times her usual dose of insulin. Could have been catastrophic. Now, why did they give that dose? Because that's what they usually give. The ADA pushes very high doses of basal insulin that forces the patient to be eating all day long to cover the insulin. This is very commonplace. It's also commonplace in the use of insulin pumps. So that's our first special subject. For years, I've been preaching that doctors should not be looking at the patient's total LDL level as an indicator of potential heart disease, but should be rather looking at certain inflammatory indicators, should be looking at LDL particle size, at oxidized LDL, and I've been emphasizing especially lipoprotein small a, which seems to be the most potent factor in causing heart attacks if it's elevated. A pharmaceutical company in Carlsbad, California, Jonas Pharmaceuticals, Jonis, has come up with a product that interferes with the messenger RNA that causes the body to make lipoprotein small a. And they can achieve, at least experimentally, very substantial reductions in LP small a, maybe 80% reduction. This is in experimental status right now. It's not been approved by the FDA. They're doing clinical trials. We don't know when it will become available, or if it'll become available. There may be adverse side effects. But finally, an attack is being made on lipo small a. We did know for years that if women are deprived of estrogen, for example, they have ovaries removed at a young age, so they can no longer make estrogen, and they're not given estrogen replacement, they can have very high LP little a blood levels and get heart attacks. Next subject is a recent article in the journal Diabetes Care about a 5-year follow-up on bariatric surgery. As you may know, bariatric surgery, that is bypassing the stomach or parts of the intestines or the duodenum so that people cannot adequately digest their food, is sometimes a cure for diabetes, for type 2 diabetes. And we didn't know about the long-term effects. So someone finally did a study on a large number of patients of the long-term effects of bariatric surgery on the type 2 diabetes. Now, initially there's a substantial regression where, and by definition of regression or cure of type 2 diabetes, they mean getting the A1C under 6.5. Now that's the ADA guideline. They say an A1C under 6.5 is not diabetes, even though that's an average blood sugar of about 160, which is double normal. So to get your blood sugar, if you get their blood sugar down to double normal, you're saying they're cured. Well, after 5 years, 62% of the patients do not achieve an A1C as low as 6.5. 62% do not get this. So 2/3 of the patients who were signing up for a cure don't get cured. And a cure is not really a cure. It's blood sugars that are double normal or under double normal. Another special subject. Many people have been worrying about the questionable availability of metformin in the USA. One version has been approved by the FDA and is now on the market. It's made by Sun Pharma. It's extended release metformin, which is the kind that I use most commonly. Although we were getting it in the old days in 500 milligram and 1,000 milligram doses, it now only comes in 500 milligram doses. So one has to take multiples of 500 milligram to get to the usual replacement dose, which for many people is 1,000 milligram twice a day of the extended release. So you now can get it from Sun Pharma. If your pharmacy says it's not available, you tell them they should ask their distributor for the product made by Sun Pharma. Now, for years, I've been mentioning that doctors are afraid of lawsuits. They're so afraid of lawsuits that if the guidelines by the big associations, medical associations, are harmful to the patient, they would rather go by the guidelines because they're less likely to get sued. So here's the latest edition of Medical Economics that has the headline, Confronting Lawsuits. Doctors are encouraged to worry more about lawsuits than about giving patients adequate medical care. Another special subject. In the January 20th, 2020 issue of the New England Journal of Medicine, there's an article that points out that for healthy women over the age of 70, the group with the highest LDL, serum LDL, live the longest. This sort of contradicts the propaganda that you've been getting for years and years that LDL is harmful. In reality, there are problems with oxidized LDL, which is really associated with heart disease, and also with small, dense LDL. On the other hand, large, buoyant LDL particles are not associated with heart disease. So one has to be very careful, especially if the doctor is saying your LDL is too high, you got to take a statin. Find out whether it's the small, dense or the large, buoyant. Also, you should find out what your LP small a is, and the other inflammatory markers that I've mentioned over the years. Before we begin answering questions, I want to remind you that my answers are generic answers. I cannot see your entire medical history. I cannot examine you. So I have to guess at the solution to your question. And the answer is likely to be of interest to all of the listeners, but it may not solve your particular problem. So you should see a physician for an answer that might be more likely to solve your problem, but the answer I give might be more educational. I, re, I recently read that antihypertensive meds are best taken at night, particularly for diabetics due to autonomic dysfunction. Is this the case? Well, it's sort of the case. There's a condition that's common amongst diabetics called non-dipping. In normal individuals or people with mild hypertension who are not diabetic, the blood pressure appears to drop overnight. It might drop by maybe 5 millimeters of mercury, small amount, and diabetics frequently are non-dipping. Their blood sugars may not drop overnight, and statistically, most heart attacks occur during the first 3 hours after you wake up in the morning. So there's reason to keep blood pressure low in the early morning hours after you get up. Well, how do you do that? One way may be to take a rapid-acting antihypertensive drug upon arising in the morning. Another way may be to take a long-acting antihypertensive drug at bedtime. So, depending upon what drug the doctor wants to use, he may well be giving it at bedtime to cause overnight dipping of the blood pressure. Why does a long-term type 1 need less insulin? Well, I don't think that happens automatically because it's long-term. First of all, you could be using one of the newer insulins that might be more potent than the insulin you were taking before. For example, Humalog is twice as potent, twice as powerful as regular insulin. Novolog is about 1.5 times more powerful than regular insulin. So that's one possibility. Another possibility is you may be eating less carbohydrate because more people are trying low carbohydrate diets. Maybe you have lost some weight, so you're not as insulin resistant as you may have been before. Maybe you're eating less protein. Protein does require some insulin for coverage. Maybe you're getting more exercise. Maybe you read my book, Diabetes Solution, which covers a number of ways to reduce your insulin requirements. Now, those are all the things I can guess of. It's all speculation. You may have another reason that I couldn't think of. Is there any research or anecdotal information that you have about the effects of stimulants for the treatment of ADD on blood glucose? That's ADD is attention deficit disorder, and that's frequently treated with stimulants. For a type 1 diabetic, getting a moderate to high dose of stimulants, of a stimulant called Vyvanase. So yes, stimulants can cause increased blood pressure, and many of them increase norepinephrine, they can increase blood sugar, and norepinephrine can increase blood sugar. So that is a valid possibility. Are type 2 diabetics more likely to develop pancreatic cancer? Actually, the literature does I've seen articles that do say that both kinds of diabetes, especially type 2, can be associated with uh, greater frequency of pancreatic cancer, which is, by the way, pretty rare. However, there's one point that most patients and most doctors don't know, and that is that pancreatic cancer, while after discovery usually rapidly leads to death, to get to the point where you know you have pancreatic cancer may take many years, 10 years after it first starts to develop. So it evolves slowly initially, and then by the time symptoms occur, it's advanced and metastasized too far to reverse. But if you have type 2 diabetes and your doctor does routine blood tests, he can test for pancreatic amylase and lipase and get clues to the fact that the pancreas is being damaged much earlier on before you get symptoms. So it is possible to screen for pancreatic cancer if you're already diabetic. Because it's such a rare disease, oncologists don't recommend screening everybody for pancreatic cancer. I am 34 and just diagnosed diabetic. Not on insulin. My blood sugar is averaging 120 to 125 with occasional spikes as I continue to learn how different foods affect me. How long is it safe for me to maintain these numbers? Good question. As you may know, I'm a stickler for normal blood sugars, especially for people who are newly diagnosed, because these people usually are still making insulin. And as this patient says, he or she is not taking insulin. So we want to preserve beta cells. And because high blood sugars are toxic to beta cells, we don't want high blood sugars. Well, the ADA would say 120 to 125 is below normal by their standards. To me, it's 50% above normal. Minimal mortality occurs on non-diabetics who have average blood sugars around 83 milligrams per deciliter. And 125 is about 50% greater than 83. So I would say that you want to get your blood sugars down right away and keep them down in order to preserve beta cells. Now, you want to know how to do it, read my book, Diabetes Solution. I am newly diagnosed type 1, 22-year-old woman. I've been told my blood sugar rises because of my monthly cycle. I've come across this in your book. How do I deal with this? Well, I think I deal with it in the book, but I do two alternate things. First, I might try extended release metformin every day for life, or until your periods stop occurring. That tends to stabilize things, but it doesn't work for all women. It works for some women. Getting some kind of birth control treatment to stop the periods definitely works. So one option is to take metformin, extended release. You have to taper into it because it can cause diarrhea if you start it too fast. So you'd start with a small dose and gradually increase it. The other alternate is to see a good reproductive endocrinologist who can prescribe a birth control mechanism. It could be pills. It could be an intrauterine device, something that stops periods. And that's basically it. So a good reproductive endocrinologist would be helpful. I have been type 2 for 20 years and extremely underweight. What can I eat in order to put on 15 or more pounds and not raise my blood sugar? Well, what I usually recommend is increased protein and insulin. Insulin is an anabolic hormone, which means it builds tissue. It builds both muscle and fat. And you could increase the protein and see if your blood sugars go up, and they probably will if you're a type 2 diabetic, and you may need insulin to cover the protein. I'd suggest that you read my book, Diabetes Solution. I was diagnosed with congenital short pancreas. I have only the head, basically 1/3 of a normal pancreas. A new GI doctor thinks I may have an exocrine pancreatic insufficiency. It's called EPI. That means that the cells in the pancreas that make digestive enzymes are deficient. There are not enough of them because not enough of the pancreas is left. So this person has EPI due to a slow, unintended. The doctor thinks he has EPI because he's been losing weight. Lost 25 pounds in the past 12 years. So now he wants, I'm reading your book, but the amount of diabetes, of calories from fat seems to be high. With my presumed EPI, I'm thinking it may not be a good idea. Do you have any suggestions? Well, we do not, in my book, deliberately recommend a lot of fat. I recommend a lot of protein and whatever fat comes with the protein. Now, it happens that with digestion, the food product that requires the most digestion, the most enzyme, is fat. That's usually the problem product to digest. So if people have EPI, they have trouble digesting fat. They'll have trouble digesting protein and carbohydrate, but usually fat is the big problem. So you can use less fatty foods. You can avoid butter. You can avoid vegetable oils. You can go after lean meat. Use chicken without the skin, etc., etc. It's all common sense if you want to cut back on fat. We're not recommending these ketogenic diets where you push the fat and lower the protein. My 7-year-old daughter was diagnosed with type 1 diabetes 5 months ago. She has started your program, but her endocrinologist said she has had too many scary experiences where people who have kept their ketones high have got into trouble. Well, first of all, I'm not recommending keeping ketones high. I don't even recommend that you measure ketones, except if you have a dehydrating illness. She said the reason for my daughter's A1C being 5.3 was that she was still in the honeymoon period and not because she was carbohydrate restricted. Could you please advise us? Well, the doctor is certainly not correct. I don't advocate keeping ketones high, but you might want to find a kindly pediatrician who will listen to common sense. It's unfortunate that the endocrinologists tend to go by the ADA guidelines and are fearful of cutting carbohydrate, fearful of normal blood sugars, etc. They're all afraid that if they don't follow the guidelines, they're going to get sued. And a kindly pediatrician, ask your friends or neighbors if they have a kindly pediatrician, or maybe your own pediatrician may be kindly and may be willing to listen to what you say and make the proper prescriptions as we indicate in our book. What is the best way to transition off an insulin pump and onto injections? I am a late onset type 1, and this person complains he has erratic blood sugars on the insulin pump. Well, this is a very common question. I have yet to see anybody who, after a few years on an insulin pump, has normal blood sugars. People who are still making a lot of insulin at the beginning may have good blood sugars at the start, but as you create scar tissue from the pump, and also because the algorithms for the pump never work, I can understand why this person can't control his blood sugars on the pump. So I would say you read my book, and as if you were a new type 1 diabetic, and start from scratch. I would also suggest that you get a continuous glucose monitor like the Dexcom, so that you could be warned of any emergencies. You should have had this when you had your pump, when it was even more needed, but get a Dexcom, read the book, and start off as if you were starting from scratch. The insulin doses that you were getting with the pump may not have been the insulin doses that you really need. They're the doses that the pump algorithms tell you to follow. As I was reading your 4th edition diabetes solution book, you stated that the use of a continuous glucose monitor device has been found to be inaccurate. Is this still the case, for example, for the Freestyle Libre system? I do not say that these devices are inaccurate. I say that punctures for obtaining blood that are not in the fingers, that are usually if they're for interstitial blood, that is blood in the tissue fluid, glucose in the tissue fluid, not actual blood, and the CGMs are not measuring blood sugar, they're measuring interstitial fluid sugar. It happens that the interstitial fluid sugar is usually 20 minutes to 30 minutes behind the blood sugar. So it's not that it's inaccurate, it's that it's delayed. And if your blood sugar is dropping rapidly, there'll be a big difference between the true blood sugar and the interstitial fluid sugar. If your blood sugar is dropping very slowly or rising very slowly, there may be no difference. So my CGM sometimes reads right on the nose, no different from the finger stick. Sometimes it's 1 milligram per deciliter difference. Sometimes it may differ by such a degree that I can't rely on it at all. And I'll have to recalibrate it. So if you see a blood sugar that looks crazy, recheck. And the CGM reading may really be crazy. That's about all I could say. And the Freestyle Libre system doesn't even give you alarms, so you don't get a warning if you have a low blood sugar. You have to be thinking of checking it to get the warning. So if you're in a stupor, a half in and half out of consciousness, because you have a very low blood sugar, you're not going to get an alarm with a Libre system. So use the Dexcom. I'm type 1 and my BG plummets rapidly after just 1 minute of cardiovascular exercise. I find that very hard to believe because I do very extreme cardiovascular exercise where I get my pulse rate above my theoretical maximum, and I don't see a big drop in a minute. But let's see what I'm recommending for this fellow. First of all, I'd want to know if I'm taking the right amount of basal insulin. It could be that you're getting an excessively high dose of basal insulin, which the ADA frequently recommends. And I described recently a patient of mine who was given 10 times her usual dose of basal insulin when she was in a hospital, and had rapid drops all day long. So how do you find out what your proper basal dose of insulin should be? You don't eat breakfast, don't eat lunch. By dinner time, you could have a meal, but you check your blood sugars all day long while you're not eating. Basal insulin is supposed to cover the fasting state, and it should not be lowering your blood sugar while you're fasting. So if you find that you're not eating and you're dropping all day long, you're getting too much basal insulin. So that's one possibility. Now, if your blood sugar is dropping rapidly, the best treatment for it that I can think of is using liquid glucose. I have liquid glucose with me all the time, and I have a shot glass for measuring it, or you could use a plastic measuring spoon, and I know how much 1 teaspoon of liquid glucose raises my blood sugar, and it works faster than the tablet sugar, so you could, while you're exercising, using liquid glucose. It's also wise to have a continuous glucose monitor in place for if you forget to check your blood sugar to give you a warning. And you might shoot for when you take the liquid glucose, that should be calibrated. For example, let's say 1 teaspoon raises you by 7 milligrams per deciliter. So you shoot, instead of for a blood sugar of 83, you shoot for 90, 95, maybe even 100 while you're exercising, knowing that it's going to come down. So those are a few suggestions that I could make. I'm borderline diabetic. What do you suggest? Well, I suggest that you read my book, Dr. Bernstein's Diabetes Solution. It's interesting that what other experts call borderline, which might be a fasting blood sugar of 100 or 110 or 115, or blood sugar after meals of 130, 120, I would consider diabetic, and I would be treating, and I'd start with diet. There's a possibility that you might need diet plus a relatively mild agent like metformin. But check your own blood sugars, see what you're running. If the definition of pre-diabetic, there are many possible definitions. One definition could be that you have a first-degree relative who's diabetic, or you may have a second-degree relative that's diabetic. That might make you pre-diabetic also. Look at the numbers. I can get fasting glucose in the normal range, 80 to 90, by taking metformin 500 milligrams, extended release. Nephrologist says lowering glucose with this drug is dangerous. This person has stage 2 to 3 kidney disease. Well, it happens that metformin is partially cleared by the kidneys, so if you have what's called renal insufficiency, the actual blood levels may be higher than the usual therapeutic dose, but I doubt that that's going to cause significant problems. I think that you should get a second opinion from another nephrologist who has more experience, perhaps. And I think that you should also work on normalizing your blood sugars. Do whatever it takes to normalize blood sugars, because diabetic kidney disease is caused by by high blood sugars. Do you agree with Dexcom that those using their G6 continuous glucose monitor no longer need to check their blood sugars? That's an absolute lie. And the reason that Dexcom makes this claim is because their competitor made that claim to make them look better than the Dexcom. In reality, the competitive device is not as good as the Dexcom because it doesn't give an alarm. And Dexcom people should just be pointing out that the competitor is lying, number one, and number two, you don't get an alarm, so what's the value of the device? The time when a diabetic is most in jeopardy is when they're sleeping, and that's when you need an alarm to wake you up. So you do need, my patients with a G6 will correct their readings when they're erroneous by getting a blood sugar measurement. They also will find that the readings may be slightly different than their blood sugar reading, like might be a blood sugar reading of 70 and the Dexcom says that they're 83. Well, for that 70, the patient may want to make a correction with liquid glucose. So it's handy to, or it's important to be able to get a real blood sugar, which is from your blood, not from the Dexcom, periodically. I have my patients get blood sugars periodically during the day, and that's in addition to whatever the Dexcom told them. So we play it safe by still sticking the fingers. And as I said, you needed to periodically calibrate the Dexcom, as you do with a competitive device. Do you have any experience with or comment about Trulicity? It seems to be highly advertised for controlling blood sugar, but is not insulin. Yeah, Trulicity is a GLP-1 agonist that works for a week. You inject it, and it works all week long. And it seems to defeat the major purpose of GLP-1 agonists. Now, there are two purposes. There's the purpose that the ADA claims, which is that it can lower blood A1C slightly, maybe by 0.3%, which is very small. That might be lower average blood sugar by 12, or in some people by 4. But I find that for many people, it controls appetite, may prevent overeating, or make it easier to eat a low carbohydrate diet. So that's, to me, the real value to a GLP-1 agonist. And as with many other drugs that lower appetite, if you have them working 24 hours a day, you tend to down-regulate their receptors, and eventually they stop working. If you take them only at the times of the day when you'd be overeating and use a rapid-acting GLP-1 agonist, let's say you only overeat after dinner. So just before dinner, you take a rapid-acting GLP-1 agonist. It starts working maybe an hour later. So after dinner, it's working, and you're not snacking until bedtime. And then you're not stimulating those receptors for the agonist 24 hours a day. You're only working on them for a little while. Whereas you do it all week long, it doesn't seem to have any effect on the appetite. So it's of very questionable value. I say no value. I wouldn't use it on my patients. Do you only recommend the non-generic form of glucophage? Well, the brand name of a product is only made in Germany. I think it's made by Merck. It may only be made for experimental laboratories. So it's certainly unlikely that people in the USA can get it. And I don't know if people in other countries can get it. That's basically it. So it's not that I'm recommending non-generic. All that we have here in the USA is generic. So that's what I currently recommend. What do you think of the product put out by Dr. Al Sears through his Primal Force label, entitled Recovery Metabolic Rescue, intended to help for the control of blood sugar? Okay, I looked it up on the internet. It says it contains unique herbs, minerals, and nutrients. And they're all secret. And he has many claims. He says it cures many ailments. And I find that it's sort of hard to believe. If you believe in magic and want to try the many magical solutions, cures for diabetes that you can find on the internet, this is one of them. I doubt very much that it has any significant effect. There's also, of course, the problem that it may contain pesticides, it may contain toxic substances. You don't know what's in it. So, and the ingredients are secret. Does vitamin C affect the accuracy of the Dexcom G6 like it affects the accuracy of blood sugar meters? And are there any other supplements that can significantly affect the accuracy of blood sugar meters and the Dexcom G6? Well, first of all, Tylenol can adversely affect the accuracy of the G5, and the Dexcom people say that it does not adversely affect G6. So that apparently has been a change since the release of the G6. Now, any blood sugar meter that uses glucose oxidase in their strips will have accuracy adversely affected by large amounts of vitamin C in the blood. Now the question may be, how big a dose can you get away with? I suggest that you not go above 250 milligrams per day. There's also another reason for not taking high doses of vitamin C, and that is the fact that it can get metabolized to oxalate, which is the basis of the most common form of kidney stones. So don't take large doses of vitamin C. It can affect probably the G6 and the G5 and most of the blood sugar meters. I don't know of any blood sugar meters that don't use glucose oxidase, but there may be some. In 2 months, I was able to lower my A1C from 7.00 down to 6.1, which, by the way, is still not normal. It's an average blood sugar of about 140. Following your guidelines, 6-12-12, that is low carbohydrate. To my surprise, my cholesterol shot up to 250. What do you think happened? Well, what usually happens when people really have normal blood sugars, and you don't have normal blood sugars yet, is that the small dense LDL diminishes, the large buoyant LDL may go up, the oxidized LDL can drop with lower blood sugars. LP small a may drop. I suggest that you read the scientific literature out there on the internet about the cholesterol myth and about the years of bribery by food companies to blame heart disease and obesity on fat, dietary fat, and total cholesterol. And in large populations, as I've mentioned over and over, the lowest mortality is with blood sugars around 83 milligrams per deciliter. So the game plan for survival, long-term survival, is normal blood sugars, not low cholesterol, total cholesterol. Fasting advice for a type 1 diabetic, is it safe? Well, first of all, it depends what you mean by fasting. Um, most people fast overnight. Um, some people in various religions fast during religious holidays, maybe for a day. Maybe they have only one meal a day for several weeks. I don't know. But usually the occasional fasting is not harmful. Does it serve a purpose? Usually not. Uh, People who fast, I've seen patients who fasted to lower their body weight. And what happens is, as soon as as they stop fasting, they start regaining fat and not regaining much of the muscle that they lost when they fasted. So I don't recommend fasting for weight loss. Certainly not fasting for controlling blood sugars. The one situation where fasting may help control blood sugar is if you want to see if you're really taking the right dose of basal insulin, and then you fast for a day and look at your blood sugars, and if they're going up while you're not eating, you're not getting enough basal insulin. If they're going down while you're not eating, you're getting too much. And you could do this from time to time as a double check on, are you getting the right dose of basal insulin? So that's basically my suggestions. Have you heard of any researchers harvesting some of the patient's remaining beta cells, growing them in vitro, and reintroducing the newly grown beta cells, thus avoiding any need for immunosuppression from cadaver transplants? No, I've not heard of this. It's difficult and probably traumatic to harvest beta cells, but there are important points to note. Beta cells survive and replicate best when they're in a natural environment, which includes what's called the paracrine effect. Paracrine effect is the effect of hormones on one type of beta cell that makes one type of hormone on the adjacent beta cells that make another type of hormone. There's alpha, beta, gamma, delta, and epsilon, at least 5 different kinds of beta cells making 5 different hormones. And these hormones not only affect the metabolism of the body and blood sugar and so on, but they affect the survival of the adjacent beta cells. So it's important to put the beta cells back where they belong. And that's a very difficult job and makes beta cell transplanting very difficult. Another thing they need is adequate vasculature. You need nearby blood vessels that will accept insulin from the beta cell, but will also nourish the beta cell. And we're really talking about beta cells, not the whole islet. So you need a beta cell in an islet for it to function optimally, and that makes the whole ball game very difficult to do. There may be some ways down the road of getting beta cells to proliferate in situ, that is, where they belong already and haven't died off yet, and you make them replicate there. That's the most hopeful solution. How can I tell if I'm a type 1 or type 2 diabetic? Well, first of all, uh, it doesn't really matter. What really matters is what your blood sugars are, not what you call it. You could read my book. That'll help you tell the difference. But even there, it's a spectrum. It goes from very mild type 2 at one end, that they call pre-diabetic, all the way up to people with absolutely no beta cells, which is a full type 1. And then you can go even beyond that, because there are people, obese type 1s, which are becoming more and more common thanks to the ADA high carbohydrate recommendations. You're getting obese type 1s who are both type 1 and type 2. So you have this whole spectrum. So one guy is going to call this point in the spectrum type 2 and this point type 1, and another doctor might call another point in the spectrum type 2 and another point type 1. So it's a matter of opinion. What's important is, what are your blood sugars and what does it take to normalize them? And that's trial and error and experimenting. My doctor said insulin is next. Trulicity is $750 a month after I run it through my insurance. She has recommended NPH from Walmart at $25 a month. Is that a good recommendation? I have read your book. That is how I've lost 85 pounds. Okay, so how can he get the cost down of his basal insulin? Well, first of all, most doctors, as I've said over and over, recommend much higher doses of basal insulin than patients need. So you could get your amount of insulin down a lot if your basal requirements are much less than the doctor is prescribing. You could also save a lot of insulin by not using insulin pens. The insulin pens have these very fine needles that get dull after maybe 1 or 2 uses, and you have to lose at least 2 units of insulin to fill a needle on a pen. So you're throwing away 2 units every shot if you're throwing the needle away after every shot. And if you're not throwing the needle away after every shot, they're going to get dull after a couple of shots. So you buy Trulicity in a vial and use it in a syringe that you reuse, and reuse the syringe in the special way that we teach you in my book, Diabetes Solution, and you won't be losing insulin. So between the possible lower doses and not throwing away 2 units with each shot, you might save, I don't know, maybe 80% of your insulin. You could switch to NPH insulin, which is a lot cheaper, but NPH is not a long-acting insulin. It's intermediate acting, and you might have to take it 3 or 4 times a day if you want to use it as a basal insulin. It has the advantage that it can be diluted. It has the slight disadvantage that you have to shake it up before you draw it out of the vial with a syringe, and it's very inexpensive. So you might use NPH insulin 3 or 4 times a day. You should also be taking insulin before meals. So you could use regular insulin, which is very inexpensive at Walmart, before meals. That again might reduce the dose of Trulicity that you're getting, because, as I said, the doctors like to give high doses of basal insulin and use those high doses to cover meals, forcing patients to eat all day. So that sort of covers it. There are ways of getting the cost of Trulicity way down, and you can use NPH 3 or 4 times a day. Well, that's it for our March session. Please join us again on Wednesday, April 29th, 2020, with another session. Look forward to seeing you then. Thank you.